This is an introductory lecture on neuroradiology given as part of the Neuroscience course in the spring semester of the first year of medical school at the University of Pittsburgh. Understanding this lecture, it will help a lot if you've already heard the Introduction to Radiology lecture that was given as part of the anatomy course in the first half of the year. The practice of neuroradiology includes imaging of the brain, the spine, and of the ear, nose, and throat. That might seem like an odd thing to throw in along with the brain and spine, but if you consider the function of the cranial nerves and the intricacies in the anatomy of the skull base, it makes a lot more sense. The modalities that we're going to be considering in this lecture include conventional radiographs, plain films, x-rays, computed tomography, magnetic resonance imaging, and then a few less commonly known modalities that include myelography, angiography, which we've covered in the previous lectures, and positron emission tomography, which we're only going to talk about briefly. Most of what we're going to be talking about is CT and MRI, because those are really the workhorse modalities in neuroradiology. Conventional radiographs are dated examinations within the practice of neuroradiology. Remember the synonyms, x-rays, and plain films? There are only a few times when these are really useful to us in the 21st century. We can certainly perform x-rays of the skull. Here's a frontal projection and a lateral projection of the skull. You can see how dense the skull is, except for this little line here where a neurosurgeon has drilled into the skull, taken off a piece of skull to perform surgery, and then put it back in place. Other interesting things that you can see here include a radiodense tube that has been inserted into the center of the brain that is draining CSF because this patient is incapable of draining CSF in the usual fashion. These are called ventricular shunts. This particular ventricular shunt has been shunted down towards the abdomen. Now, how do I know that this portion of the shunt is actually within the brain and not just sitting on top of the patient, because we know in conventional radiographs that it's sometimes hard to know what's in front of what. That's why I need two projections, so that I can see that in both of these projections, the shunt extends deep into the center of this skull. So it is truly in the middle of the skull. Unlike this portion of the shunt tubing, which might look like it's inside the skull on the lateral projection alone, but when you see it on the frontal projection, you can see that it's actually alongside the skull. We used to do plain films of the face in order to look for facial fractures, but CT has completely replaced conventional radiographs for this use. We used to do plain films of the face and skull base to look at the paranasal sinuses to see if patients had sinusitis. And you can see that there's air filling the paranasal sinuses here, even the sphenoid sinus looking up from underneath the chin here. Again, plain films in this situation have been completely replaced by computed tomography. Now, we still do occasionally perform plain films of the spine. They are a good screening tool, although CT does a better job at looking at most aspects of the spine, including both degenerative disease and trauma. But plain films are inexpensive, easy to obtain, and are a good initial screening tool. Notice the curvature, the normal curvature of the cervical spine. There is a normal degree of lordosis, that is curvature with the apex towards the front, lordosis of the cervical spine. That's normal. When we look at the cervical spine in a frontal projection, you can see that they're shaped like little cups, each one supporting the one above it. In the thoracic spine, the curvature is in the opposite direction. Here, on this lateral projection, there is a curve with the apex dorsal towards the back. This is normal in the thoracic spine, and it is called thoracic kyphosis, the normal thoracic kyphosis. The cup configuration in the frontal projection is no longer seen. Now the vertebral bodies look like rectangles when they are seen in this projection. They're actually cylinders, but when you look at these cylinders from the side, they look as though they were rectangles. When we get to CT, we'll get to see those cylinders looking a little more circular. Remember the attachment of the ribs as in previous lectures. Now, when we get to the lumbar spine, we've gone back to a lordotic curvature, right? There's a normal lordosis to the lumbar spine. The apex of the curvature is anterior, ventral. And here again, the vertebral bodies are shaped like rectangles when seen in this projection. Moving on to computed tomography. When you're looking at a tomogram of the brain, it's really important to go back and remember what we talked about previously about window and level on CT. So as a review, when we create an image with computed tomography, the possible ranges of values for each pixel on the CT has a range of like 4,000 different possible values. There's no way that your eye could distinguish 4,000 different shades of gray. So instead, we narrow down and look at just a window of possibilities. Everything that is below that in value, we plot as black. Everything that is above that in value, we plot as white. And so, for example, when we want to look at the brain parenchyma and we want to be able to distinguish the subtle differences between gray and white matter, which can be made out on CT, we want to use a very narrow window and just focus in on a very narrow range of possibilities. What this means is that we lose all ability to look at the skull itself. The skull is just a vague white blob. We also lose the ability to look at the scalp, right? The fat of the scalp looks just like the background air when we have this narrow window on a CAT scan. If we want to look at those objects, we can. We can widen out our window like on this side. And this is the exact same data as this. It's a cut through the exact same level, same data, just shown, displayed with a different window. And now you can really make out a lot of the details of the skull. You can distinguish the inner and outer tables of the calvarium. You can distinguish the scalp itself from the surrounding air, which you couldn't do before. So which of these is better? They're both absolutely necessary. And in order to evaluate a CT of the head, you've got to be looking at the brain using this window and the skull and scalp using windows like these. They're both really important. Now let's look at some of the different anatomy that we can see on this CT scan. Here's what a vertebra looks like when you see it on a cross-sectional, that is transverse, CT slice. As promised, the vertebral body is looking a lot more circular because of its true cylindrical configuration. Here we're cutting that cylinder along its axis, and you can see that it's looking a little more circular. But now you can make out all of the other parts of the vertebra, the pars, the lamina, the transverse process, the spinous process, and the facet joints that we're not going to talk about in detail. What's really annoying, though, is that you just can't make out any of the soft tissues here in the spinal canal. You can't distinguish the CSF that we know is surrounding the spinal cord itself. Even if I narrowed the windows, that might help. These two are too close together and there's too much artifact from the surrounding bone. It's just always going to be really hard to tell those apart. Remember that when we come back and talk about myelograms. Magnetic resonance imaging gives us a much broader range of ways of interrogating the tissue. Unlike a CAT scan that looks at just one aspect of the tissues, that is, how well they absorb X-rays of a particular energy. Magnetic resonance imaging gives us an opportunity to hammer these tissues with a wide variety of different radiofrequency pulses in various predictable sequences. And these pulse sequences define how we're looking at the brain. So we get a wide variety of different outputs when we're doing an MRI. We like to talk in terms of T1 and T2 weighted sequences, and sometimes you'll see oversimplifications like on T1 the CSF is dark and on T2 the CSF is bright. But those axioms are so simplistic and MRI has become so complex that the axioms are essentially worthless. I am showing you two different pulse sequences that demonstrate the same anatomy here. This one happens to be a proton density sequence, and this one a T2 weighted sequence. And in fact, the CSF is bright on a T2 weighted sequence. And they show different aspects of the anatomy. You can see how well you can see the fluid, the CSF, both in the ventricles and surrounding sulci. We'll go into that anatomy later. How well you can see it on this T2 weighted sequence. But if you go to the proton density sequence, you can really make out the deep gray structures from the surrounding white matter. So there's advantages to both of these. And so we have a wide variety of different pulse sequences that we analyze on every single MRI of the brain. Another big advantage of MRI is its multiplanar capability. Whereas a CT scan, a CAT scan, is inherently restricted to the transverse plane, we certainly do some reformatting to overcome that, but it is inherently restricted to the transverse plane. The MRI has no such restrictions. In fact, we could image in any angle, any weird obliquity we wanted to. If I wanted to follow some weird cranial nerve along its path, I could image right along the path or right perpendicular to the path of that nerve. But we tend to restrict ourselves usually to the predictable planes of imaging of axial, coronal, and sagittal. Why? Because we understand the anatomy well in those planes, and it makes all of the MRIs look similar, which makes us much more efficient. This particular image is a sagittal image, right cut down the center of the skull, right down the middle. Nose would be out here, eyes out on either side about here. There's the tongue, some teeth right there, lips. So that gives you some orientation. Here is the cerebrum, cerebellum, and brain stem leading down into the cervical spinal cord. MRI, particularly good at analyzing the spinal cord. Here's an MRI of the cervical spine. Remember this normal lordotic curvature of the cervical spine, still evident as we see the vertebral bodies stacked one on top of the other. Notice how well on this T2 weighted sequence we can distinguish between the spinal cord and the surrounding CSF. Not quite as well on the T1 weighted sequence over here, but on the T2 weighted sequence over here, it's really easy to distinguish between the spinal cord, which is relatively dark, and the surrounding CSF, which is extremely bright. This overcomes that problem we were talking about on CT of the spine. It might look as though the spinal cord is tapering off here. It's getting narrower and narrower and essentially disappearing and doesn't even hook up to the brainstem. Well, that's not true. The problem here is that anatomy doesn't sit in one perfect plane. You might imagine in an ideal world that the spinal cord sits right smack in the midline sagittal and never wavers from that position, but that's just not true. The spinal cord might wave from one side to another. Someone might turn their neck or slightly or tilt their neck from one side to the other such that the spinal cord, not all of it, is right smack down the midline. And so what has happened here is the spinal cord has taken a little bit of a detour out of the plane of imaging and then come back into the plane of imaging as the brainstem there. This segment is normal cord. You just need to look one cut over from where we are here and you'll be able to see that normal cord. We'll come back to that concept when we do the pathologic images. Myelography. How do we perform a myelogram? To perform a myelogram, you first have to do a lumbar puncture. You put a needle through the patient's lower back into the CSF that surrounds the spinal cord. And unlike a lumbar puncture where you withdraw some of the CSF to test it, in a myelogram you inject some iodinated contrast material, not the same stuff we put into the veins, but a cousin, a similar material, into the fecal sac, into the CSF. And you allow it to slosh around, mix up with the CSF, and all of a sudden you have contrast enhanced all of the CSF. What does this do for us? Well, remember how I was complaining on that CT that I couldn't tell the difference between the CSF around the outside and the spinal cord on the inside? Well, you sure can see it now. Look how well that CSF shows up. And you can imagine that an abnormality of the spinal cord or a mass taking up some of the CSF would be much easier to see. You can even see some of the segmental nerves that come off of the cord within the spinal canal there. So this is one way. MRI was one way, and myelography is another way to get over this problem of being able to distinguish the different tissues within the spinal column. Myelography has an advantage over MRI because it combines really good information about the bones, which MRI is really bad at. MRI is bad at bones, but this is a CT image, so the bones show up real well. Combines imaging of the CSF with good imaging of the bone, particularly useful in planning surgeries. Okay, let's move on to angiography. We've done an introduction to angiography in previous lectures, but let's go into it a little more again and review some of it in anticipation of analyzing this anatomy in more detail. This is a frontal projection. This would be a conventional radiograph of the skull in frontal projection. Here are the orbits. There's the nasal cavity, paranasal sinuses, and this is the calvarial vault. These are monitoring leads, and we can ignore them for this discussion. What we did here was we took a plastic catheter and placed it into the femoral artery, which is a nice superficial artery, easy access, snaked that catheter up through the aortic arch and into the common carotid artery, and then from there into the internal carotid artery, and we injected iodinated contrast directly into the internal carotid artery, and then filmed it repeatedly with about 6 frames per second as it flows into the intracranial vault. Okay. Now, you might look at this and say to yourself, this is nice, and I get a pretty good look at the vessels, the internal carotid artery, and all of its branches, but I wish all of those bones weren't in the way. This is called a digital subtraction angiogram. What we did was we took a picture of the skull before injecting any contrast, and then we took a picture in the exact same location after injecting the contrast, and we subtracted those. What you end up with is a picture that just has the iodinated contrast, and all of those bones are out of the way. Now we can see the vessels in much greater detail. Another big advantage of angiography is that it's not just one image. It's actually a movie, a video clip of images over time. And you can watch the flow of contrast, by which I mean the flow of blood, into these arteries and throughout the brain. For example, this is an early arterial phase image. We're going to image, I'm not going to show you all the pictures, but these pictures arrive at about 6 frames per second, so I'm just going to pick ones that exemplify different phases of imaging. This is the early arterial phase. Now we're kind of into a late arterial phase. You can see more of the distal branches, some of the smaller arteries coming out into the periphery. We're into sort of a late arterial phase here. We can even start to see maybe some of the capillaries filling out peripherally. Now you get a really good look at even the smallest of the arteries in the brain. Now we're into the capillary phase of imaging. You can see a blush of brain parenchyma itself as the capillaries fill. right? We've lost some of our imaging of the larger arteries. You can still see some of the more distal ones, but we're pretty well into the capillary phase. At this point, the arteries are essentially emptied of contrast. You can still sort of make them out like little ghosts. There's still plenty of blush within the brain parenchyma itself, but now we're starting to see filling of the venous structures. So this is an early venous phase of imaging. This is a later venous phase. You can start to see the large dural venous sinuses, and the arteries have almost completely emptied of contrast. Our next modality is positron emission tomography, or PET. This comes from a family of modalities known as nuclear medicine, in which we take analogs of molecules that are normally used physiologically and make them radioactive so that we can detect them. For example, in positron emission tomography, instead of glucose, we replace that with fluorodeoxyglucose. Fluorodeoxyglucose undergoes radioactive decay, gives off positrons, which annihilate with electrons. Remember, positrons are antimatter, so they annihilate with electrons, and they produce high energy photons, which we measure, and it tells us where the glucose is accumulating. There is very poor spatial resolution on a PET image. You can barely make out that this is the shape of a skull in transverse section. You can sort of make out the brain in the middle here, but boy, can you make out the tumor, right? Tumors take up much more glucose. They're very fast growing, and so that's why the tumor shows up well. For your consideration, you might notice that in the center of the tumor, there's an area that does not use much glucose. And I want you to think about why it might be that in the middle of this aggressive, fast-growing tumor, there's an area of that tumor that doesn't use any glucose. Weird, huh? Moving on. Okay, let's talk about contrast agents. I know that we've talked about this in previous lectures, but it's so important to our discussion in neuroradiology that it's worth reviewing these concepts. The purpose of contrast agents is to have two different tissues that look the same before you give contrast, and then after you give contrast, they are easily distinguished from one another so you can tell which kind of tissue it is. For example, we most commonly use this in the setting of intravenous contrast, where we inject a contrast agent into the bloodstream. We can see where that contrast agent goes, and we know which areas are receiving the most blood flow. In the setting of neuroradiology, there's another really important effect. That's the blood-brain barrier. The blood-brain barrier is the endothelial lining around the blood vessels that prevents things in the bloodstream from leaking out into the brain. A normal blood vessel will keep contrast agents in the bloodstream and out of the brain parenchyma. But an abnormal vessel, like a vessel in a tumor, for example, or a vessel that has been compromised by inflammation, will allow that contrast agent to leak out, and that leakage is something that we can detect. When we're talking about CT, CAT scans, we use iodinated contrast. Iodine does a particularly good job of blocking X-rays at the energies that we are using for imaging. So if we add iodine, and we're not just injecting free iodine, it's encapsulated in an organic molecule, but if we add iodine to the bloodstream, that will block the X-rays and it will be bright on a CT. MR agents work entirely differently. They are based on the cation of gadolinium. It has a lot of free unpaired electrons, and so it is a strongly paramagnetic agent that messes with the surrounding magnetic field and causes a bright signal on T1 weighted images on MRI, as we've discussed in more detail in previous lectures. Although we like to talk about contrast agents as intravenous, they can also be intrathecal, which was the myelograms we were talking about earlier, and they can be intraluminal, which we've talked about for fluoroscopic techniques like an esophagram. Contrast agents are not completely benign. Iodinated contrast agents produce a very large load on the heart because they have a large volume component to them. There are also the possibilities of allergic reactions to iodinated contrast agents. Although gadolinium-based contrast agents for MRI do not frequently cause allergic reactions, sometimes, but not as frequently as iodine does, they have their own problems. Gadolinium is a heavy metal, and if it stays in the bloodstream too long, it'll dissociate from its chelate and will deposit in bones and other tissues. So it needs to get out quickly. Most people's kidneys are good enough to do that, but patients with kidney failure are potentially at great risk of severe injury. Let's look at an example of how contrast agents are useful. This is a CAT scan through the brain near the vertex. And you can see at a glance that something's wrong here, something's asymmetric. The brain here is too dark, right? It's got too little attenuation, lower attenuation than this side, which is the normal side. But it's not clear what's causing the problem. If we add some contrast, it gets really easy to see the tumor that is causing all of the surrounding edema, because that tumor doesn't have a good blood-brain barrier like the rest of the brain does. So that's how contrast agents are useful. Here's the same concept as applied to MRI. If you look at the initial image, you can see that something maybe is vaguely wrong in the left hemisphere here. But once you give contrast, it's really, really easy to see what is to see where the abnormality is. This looks a lot like a tumor, much like the one on the CT of the previous slide, but this is not actually a tumor. This is radiation damage that occurred after someone had been treated for a vascular malformation. This is an iatrogenic injury. It is a classic conundrum in radiology to distinguish between a tumor and radiation damage, because they look so much alike on post-contrast imaging. Let's see if you can think back to earlier in the lecture and figure out if there's another modality that might help us in this situation, where if we weren't sure whether this was a tumor or if this was radiation necrosis, what other modality might we employ? So I often get asked the question, what's better, MRI or CT? Or sometimes people will come and say, well, we want to get an MRI because that's better. But it's not always true. They have advantages and disadvantages. MRI is advantageous when we're looking at soft tissues, by which I mean not bones. So it is advantageous because the MRI can distinguish subtle differences in soft tissues that a CT cannot, and it has that ability to use multiple pulse sequences to better delineate and characterize the different soft tissues. As we discussed earlier, MRI has a multiplanar advantage, CT restricted to a transverse plane. And MRI has an advantage of no damaging radiation. Radiofrequency pulses are radiation, strictly speaking, but they are benign. There is no harm to the patient to get an MRI. MRIs are so safe, we stick pregnant women in all the time. Super safe examination. Certainly patients who have metal in their bodies are at risk because of the strong magnetic field, and there's a couple of other ways that patients can become injured by MRI. MRI heats up the tissues, but it is an extremely safe technique overall. Unlike CT, where the radiation, ionizing radiation, can cause cancer. Now, so what are the advantages of CT? Well, CT does a better job on bones as opposed to soft tissue. CT is of much lower cost than MRI, less than half the cost of an MRI, And CTs are ubiquitous. They're everywhere. It's so easy to get a CT. If you come into the ED, there are multiple scanners, CT scanners, in the emergency department. You can't swing a dead cat at UPMC without hitting a CT scan. They're everywhere and they're easy to get. MRI is a little more tricky. You got to schedule things in advance. You need to be cleared for the MRI to make sure there's no metal in your body. CT, if you need it right away, you get it right away.